Good morning, everyone, and welcome to the UW Cardiology Rounds. Today, I have the pleasure of introducing Dr. Sophie Larson, one of our graduating fellows. She completed medical school at Loma Linda in California prior to doing her residency at the University of Michigan. She then joined us at UW for fellowship in 2018. She has been recognized as an advocate for women's health, including serving in the Women Cardiology section for Washington State ACC. She has also shown a dedication to education and served as a co-chair for the Fellow and Training section for Washington State ACC and has written several editorials for the European Heart Journal reflecting on the hypertension guidelines. During her training, I had the privilege of working with her in a study with the Women's Health Initiative, part of which she'll be discussing today in her talk, Histamine H2 Receptor Antagonism and Heart Failure Risk. Please join me in welcoming Dr. Sophie Larson.
Thank you, Dr. Chang, for that nice introduction. And thank you everyone for joining us this morning. My talk will be on histamine H2 receptor antagonists and heart failure risk. And I have no conflicts of interest to disclose relevant to today's talk. So the objectives of today's talk is to first discuss the role of histamine in the heart and then review the current data surrounding H2 blockers and the treatment and prevention of heart failure. I'll then introduce our findings from the Women's Health Initiative, looking at H2 blockers and incident heart failure. And finally, we'll discuss how our findings fit with the current literature and future areas of study. Histamine has been one of the most studied substances in medicine, and its research and development spans most of the 20th century. Histamine was first synthesized in 1907, and the development of H1 antihistamines happened in the 1940s. The H2 receptor was then defined in the early 1970s, and H2 blockers were used for treatment of gastric acid-related disorders starting in 1975. And the cloning of H1 and H2 receptors happened in the early 1990s. Histamine is most commonly released from mast cells and basophils, but many other cells can release histamine as well. There are 4 different types of histamine receptors. Most known to us are the H1 receptors, which are involved in allergic inflammation, and H2 receptors, which are involved in the regulation of gastric acid secretion. But more recently, H3 and H4 receptors have also been identified, having to do with neurotransmission and immunomodulation. And although H2 receptors are most known to be involved in gastric acid secretion, and H2 blockers are currently being treated for disorders such as GERD and peptic ulcer disease, H2 receptors can also be found in the heart. While the existence of H2 receptors in the heart has been known for some time, its role in cardiovascular physiology is still not well understood. What we do know is that there are mast cells in the myocardium which release histamine, and histamine receptors are also located in cardiomyocytes. The cardiac histamine receptor system is similar to the adrenergic system in that it is coupled to GS proteins and increases cyclic AMP, therefore increasing ionotropy and chronotropy. In a paper from the early 1980s, this table compares histamine receptors with catecholamine receptors. And as you can see, H2 receptors have a lot of similarities with the beta receptors. They both cause positive chronotropic response, positive ionotropic response, and increase adenylate cyclase. There's also known that their increase in mast cells have been seen in hearts of patients with cardiac hypertrophy and dilated and ischemic cardiomyopathy, as well as in cardiac myocardial infarction. Heart failure is characterized by neurohormonal imbalances, including activation of the sympathetic nervous system. Beta blockers are an established treatment for heart failure, protecting from the harmful effects of the sympathetic nervous system, which are mediated by these cyclic AMP pathways. And as H2 receptors are also linked to the GS proteins and increased cyclic AMP, blockade of histamine H2 receptors may have an important role in heart failure. Animal studies were then done to see if blockade of histamine is important in preventing or treating heart failure. In this study from the early 1980s, blockade of histamine by cromolyn sodium prevented doxorubicin-induced cardiomyopathy in rabbits. These hearts that were treated with doxorubicin were shown to have a dose-dependent histamine release. And in the hearts that were pre-treated with cromolyn had prevention of histamine release and protection against cardiac toxicity. Blockade of histamine receptors were also found to have prevented heart failure in dogs with pacemaker-driven tachycardia. This study is a little bit more recent from 2010, but in this study, the authors induced heart failure by rapid ventricular pacing. They showed that mast cells and histamine were seen in the myocardium, and they found a decreased reduction in EF, decreased pulmonary capillary blood pressure, and decreased cyclic AMP in hearts that were treated with famotidine. Another more recent study from 2014 took mice with H2 receptor knockouts and showed that they had improved cardiac function and less fibrosis with aortic banding compared to controls. These authors found increased LV fractional shortening, decreased LV-EDP, and less pulmonary congestion in the knockout mice. They also did a histological examination and found less fibrosis and apoptosis. And interestingly, this was also seen with mice, wild-type mice that were treated with H2 blockers. Because of these promising preclinical models, H2 receptor blockade was then looked at in humans. So this was a study from 2006 out of Japan, and this study had both a retrospective and prospective arm. And they found that in symptomatic heart failure patients, they found a decreased LV size, decreased BNP, and improved functional class in patients who were on H2RAs. In the retrospective arm, they looked at 159 patients with heart failure who received famotidine versus an age-matched control group. And in their prospective arm, they only had 50 patients, but they were randomized to famotidine versus another gastric acid secretion modulator and found that there was decreased size, BNP, and functional class in the patients with the H2 who were on famotidine. A more recent study published in JACC in 2016 by Dr. Leary out of University of Washington found decreased incident heart failure in patients on H2RAs in the MESA cohort. This is a much larger cohort of 6,300 patients. He also found preserved stroke volume, preserved LV end diastolic volume, and lower mass to volume ratio in their MRI data from these patients. And as you can see in the central illustration in the panels C and D, the strongest relationship was seen in the patients that were at the highest risk of heart failure in panel D. This was based on the ARIC heart failure risk score. Dr. Leary also looked at H2RA use on the right ventricle. In the same MESA cohort, he found that H2RA use was associated with a lower RV mass and smaller RV end diastolic volume. He also looked in a different cohort, this time in the VA CART program that had 17,000 patients, and found that H2RA use was associated with a 10% lower risk of all-cause mortality in patients with pulmonary hypertension. So alongside the preclinical data, these observations suggest that histamine signaling may be relevant to the pathogenesis of human heart failure and that H2RA use may be cardioprotective against adverse remodeling. Switching gears a little bit, as we are all well aware, heart failure is very prevalent, including in women. From 2013 to 2016, 6.2 million Americans greater than 20 years of age were diagnosed with heart failure, and 3.2 million of those were women. In 2014, an estimated 504,000 new cases of heart failure were diagnosed in women greater than 55 years of age. There's also been increasing attention to sex differences in heart failure risk factors, and clinical phenotypes of heart failure. Men are predisposed to heart failure with reduced ejection fraction and are more likely to present with macrovascular coronary artery disease and ischemic cardiomyopathy. Women, heart failure with preserved ejection fraction predominates. and traditional risk factors, including obesity, tobacco use, hypertension, and diabetes, are thought to be more predictive of risk in women. Sex disparities in heart failure also exist. There is currently a paucity of women enrolled in heart failure trials, comprising only 20 to 25% of cohorts. Therefore, current treatment guidelines are predominantly based on male-derived data. And there are still large gaps in knowledge in sex-specific mechanisms and optimal drug doses for women. Therefore, we evaluated the association of H2RA use with incidence of heart failure requiring hospital admission among postmenopausal women without a previous history of heart failure in the Women's Health Initiative cohort. Our primary aim of this study was to evaluate the association of H2RA use in incident heart failure in the WHI cohort of postmenopausal women. We also had a second aim to determine that if there is any effect modification by H2RA use in incident heart failure by low versus high risk groups, determined by the ARIC score of developing clinical heart failure. And we did this because this was what was seen in the study by Dr. Leary. And this is the largest study to date assessing the association of H2RA use and heart failure risk. The WHI provides a robust sample size with long-term follow-up, rigorously ascertained medication inventory, and adjudicated clinical endpoints, including heart failure. The WHI is a nationwide prospective cohort study of 161,000 generally healthy postmenopausal women in the United States. Women aged 50 to 79 were enrolled at 40 clinical centers between 1993 and 1998. Women were enrolled in either one or more of the 3 clinical trials or an observational study with follow-up through 2005. Participants were excluded if they self-reported a history of heart failure at baseline, reported being on both an H2RA and a proton pump inhibitor at baseline, or were missing follow-up time, resulting in a final cohort of 158,000 women. Our primary outcome was incident adjudicated heart failure, defined as the first hospitalization for heart failure. And a hospitalization was deemed to be related to heart failure after a physician review of hospital records that was initiated when a participant self-reported a hospitalization on the annual survey. And our primary exposure was H2RA use, which was modeled as a time-varying exposure. We included a number of sensitivity analyses. We first stratified by ARIC heart failure risk. We also did a propensity score analysis. And then we investigated the potential for reverse causality by excluding heart failure events which occurred during the first year of the study to exclude possible undiagnosed heart failure at baseline that may have influenced the use of H2RAs. We also examined whether the duration of H2RA use was associated with heart failure. And then we used PPI use as a comparison to confirm that treatment effect was related to H2RAs and not GERD. And finally, we excluded participants who were on a diuretic at baseline. And this was to remove participants that may have had heart failure that was undiagnosed or misclassified at baseline. Multivariable adjusted Cox proportional hazard models were used to determine the association of H2RA use with heart failure. And then H2RA use was modeled as a time-varying exposure, meaning that a participant was not classified as exposed to an H2RA until she reported using it on a medication inventory. And that classification was later changed if she reported non-use. This was done to be able to capture active use. Among the 158,000 women, there were almost 10,000 or 6% H2RA users and almost 150,000 H2RA non-users. H2RA users were more likely to be obese, more frequently used other non-H2RA prescription medications, and had a higher baseline prevalence of hypertension, diabetes, and a history of cardiovascular disease. Diuretic use was also twofold higher in the H2RA users compared with non-users. And our median follow-up time was 8.2 years. In our primary analysis, H2RA use was associated with a higher risk of heart failure after just adjusting for age, but this association between H2RA use and increased heart failure risk was no longer seen in our fully adjusted model. And also, no sensitivity analysis suggested an association with H2RA use. No association was seen when we stratified by heart failure risk in our propensity match model, when heart failure was excluded in the first couple years, as well as no association was seen for either short-term or long-term H2RA users compared with non-users. Similarly, there was no association of H2RA use with heart failure in our subgroup analyses, other than what is seen with diuretic use. However, diuretic use was not found to be an effect modifier with a PFAR interaction of 0.08. In addition, we also performed the sensitivity analysis excluding patients on diuretics, which did not find an association between heart failure risk and H2RA use. Our study has several strengths, including being the largest study to date assessing the association of H2RA use and heart failure, including almost 10,000 H2RA users in a comparison cohort of almost 150,000 non-users. Further, in the WHI, medication inventories were collected sequentially, allowing us to accurately adjust for a time-varying exposure. Incident heart failure was physician adjudicated and required hospitalization, reducing the risk for misclassification of the presence of heart failure. Our cohort also included only women, who are traditionally underrepresented in clinical trials and observational studies. And lastly, our findings were consistent across extensive, rigorous sensitivity analyses. So this brings up the question of why did our results differ from the prior study that was done in the MESA cohort? So we actually had different heart failure endpoints that were used between the studies. There also may have been differences in patterns of H2RA use, including timing and duration of use. And there were also differences in the populations that were studied. In the MESA study, the incidence of any new heart failure diagnosis, including ambulatory clinic diagnosis, was used as the outcome rather than the incident heart failure requiring hospitalization as was used in our study. And although these outcomes are related, they are not the same. Requiring admission for heart failure represents the more severe end of the spectrum, but also ensures a higher specificity for heart failure diagnosis. But this may imply that our findings, in fact, suggest that H2RA use are not associated with more moderate to severe heart failure. Also, both physiologic or non-physiologic contributors to the need for admission, such as social determinants of health and an otherwise similar disease, might have obscured the relationship with H2RAs in our current analysis. Differences in patterns of H2RA use, including timing and duration of use, may also be contributing to the differences seen between the two studies. Timing of H2RA use relative to the risk for heart failure is unknown. In the MESA data, the attenuation of negative cardiac remodeling by MRI and decreased risk for incident heart failure among H2RA users was seen in the primary analysis, which looked at baseline H2RA use. However, they also included a time-varying analysis, which did not show a significant association between H2RA use and incident heart failure, which is more similar to what our findings showed. Baseline use versus time-varying use attempt to tackle two different mechanisms of action. A baseline use analysis addresses mechanisms not anchored on active presence of H2RA drug in the body, such as fibrosis. However, a time-varying analysis is based on active use association and is suitable for assessing H2RA use and incident heart failure. The impact of duration is also unknown, but likely important. In the MESA cohort, when the time-varying analysis was restricted to participants who used H2RAs for at least 1 year, there was no significant association. And this is consistent in our analysis, which also did not find an association with either short-term or long-term H2RA use. Another possible explanation of our findings is the differences in demographics of our populations and modifying effects of these variables. The WHI cohort was all women, had a mean age of 62.3 years, and had 83% of women that were white. In the MESA cohort, there were only 53% women with a mean age of 62.3 years, and only 38% were white. Therefore, our study population had a higher proportion of women and a higher frequency of white race compared to the MESA cohort. And while sex did not significantly modify the association that was seen between H2RA use and incident heart failure in the MESA analysis, it did trend towards significance with a p-value of 0.13, and this was in a much smaller cohort. While we did not see an association of H2RA use and heart failure risk stratified by race, we did see that in non-white women, there was a point estimate towards reduced heart failure risk with H2RA use, similar to the findings that were seen in the MESA cohort. This suggests that race could also be playing a factor in the differences in our findings compared with the MESA cohort. While lifetime risk of heart failure is comparable between males and females, there are well-recognized sex differences in risk factors and clinical phenotypes of heart failure. In older women, heart failure typically presents with a higher rate of diabetes and more frequently with preserved ejection fraction. And then traditional risk factors such as obesity, tobacco use, hypertension, and diabetes are thought to be more predictive of risk in heart failure in women than men. And this may be driven by endothelial inflammation and microvascular dysfunction. Conversely, men are more likely to present with macrovascular coronary artery disease and associated ischemic cardiomyopathy. Supporting this, recent preclinical models have suggested context dependence with H2RA signaling, such as H2RA signaling may be detrimental in ischemic or lipopolysaccharide sepsis-induced heart failure, but beneficial in hypoxia or hypertrophic models. In addition, another animal studies in rats suggested that males may be more sensitive than females to H2 receptor blockade. And while the full cardiovascular effects of histamine pathways are not completely defined, it is possible that H2RAs may have a differential role in cardioprotection against incident heart failure between sexes that relate to differences in risk factors or heart failure phenotype. As the largest study to date, we did not find an association between H2RA use and incident heart failure in a large cohort of postmenopausal women. Future randomized trials are needed to determine whether the use of H2RAs are associated with heart failure risk and potential effect modification by sex, heart failure severity, or patterns of use. There is a current ongoing phase 2 trial done by Peter Leary out of the University of Washington that is looking at famotidine in adults with pulmonary hypertension. These patients are being treated with a 24-week course of famotidine. Their primary endpoint is a 6-minute walk test, but their secondary endpoints include looking at differences in RV function, BNP, and NYHA functional class. So hopefully we'll have some more answers to these questions soon. In summary, H2 receptors act similarly to beta receptors in the myocardium, and H2RAs may have a role in heart failure treatment and prevention. While prior studies showed a decreased incidence of heart failure in patients on H2RAs, our current study in postmenopausal women in the WHI cohort did not show an association. And further randomized studies are needed to clarify these findings. So just wanted to thank Dr. Chang, who's a great mentor for me on this project, as well as Karen Redding and Lexi Bassbinder, who worked with us for the methodology and statistical analysis, and Dr. Leary and Dr. Branch, as well as Garnet Anderson from the WHI and the WHI writing group who contributed on this project as well. And the WHI program is funded by the NIH, NHLBI, and the US Department of Health and Human Services through various contracts. Here are my references, and I am happy to take any questions.